Hey, Seva, it's Kingman.
Good morning. How are you?
Good, good. So we usually start about 3 minutes after the hour.
Sure.
And so that generally is there. We probably have about 30 or 40 people that get on the call. And then there are the fellows. We have 5 fellows this year, and they hang out here. And hopefully afterwards I can have them ask you some questions, and then I can ask some questions as well.
Sure. Happy to do that. So now this, they ask me, I have a CME question. Should I show it at the end, right? I just show this question at the end, right?
No, you can, it'll be part of their CME MOC. It'll be part of their MOC. So they go into the MOC and then answer it, and then answer.
Oh, okay. Okay, I won't show it. Yeah, okay.
Yeah. I mean, you could, wiggle your eyebrows and tell them what it might be, but that's okay.
Yeah.
Right? Do a little bit of that particular issue. So how are you doing in your transition? I knew that was happening. It's good to see you in Singapore as well, right?
Oh, yeah, that was great. Yeah. And well, I mean, I've been here already for almost 3 years, hard to believe, but it's great. I mean, it's a nice place. It's
3 years is about when you start to sit there and look around and say, okay, I kind of know where the landscape is.
Yeah, that's right. Well, it's a smaller place, and so I kind of know everybody already. So at Hopkins, it's been more than 20 years or 24 years, and I still, obviously, it's a huge universe, right? Here, it's a smaller place. It's nice. I have my own kind of a little operation here, and interact with medicine and anesthesia, critical care. So it's good. I mean, it's really easier, kind of, and people are kind of easier to collaborate because you literally know everybody, so you see them all the time.
You have a training program there in sleep as well as in pulmonary critical care?
There's a pulmonary critical care. Sleep was some funding issues, so we didn't have fellows for a couple of years. But hopefully it will be resolved. It was some because our hospital unfortunately belongs to UHS. So and there was some now, but now it's getting better. I think they changed leadership and in the UHS, and they had a lot of changes there because of the nationwide, knowing what's going on with this company. So, but yeah, but so yeah, I'm doing a lot of kind of also basic science collaboration with Farm Fizz and yeah, and I have clinic here.
But you've not been shy, and certainly Johns Hopkins has not been shy about trying to look for translational sorts of studies that you can do that relate to things here. I mean, we got Borker here looking at inflammation, HIV, and OSA, and that's right up your alley. So and she's kind of doing that sort of stuff.
Yeah, how's Tomas doing?
I'm sorry?
How's Tomas Flore?
He's doing great, Tomas.
Thomas is doing fine. Yeah, he's I think they and we keep working on some things with him, and the ENT people keep him fairly busy. They unfortunately, when they see a lot of clinical work, it's sort of like they get used to the 90% cut heroin. If you cut it down to 80%, they don't like it, right?
I know.
That's my analogy.
And Mateus,
If you're making too much money from people and then you sit there and say, I want to do research, they get excited.
And Mateus Dutchman is still here, right?
Yeah, Matthias is here. He's getting some traction. He just started throwing in some, throwing in some grants, and then we have, Rishi Dingra is working on some things in terms of very basic science on how on really kind of the dark matter of the brainstem in terms of how it supports and sustains rhythmogenesis, which is a kind of an interesting idea. And then we have some other people in pharmacology that are working on some new opioid compounds that don't seem to affect breathing, but seem to affect pain. But then the opposite, what happens the other way? So we got some people doing some practical things, some translational things, some IP stuff as well as that. Our stuff we can talk about after 9 o'clock. But I've been focusing with a fellow here who's going to be moving in Eriko Hamada, as well as with Matthias. We're looking at the ninth nerve. We look at the stylopharyngeus muscle, looking at what its role is in the upper airway, and now I'm developing a kind of a new construct for me at least, but it turns out to be more I read about, the more Guilleminault already said that it was happening, which is the idea of upper airway sleep health. So I had a poster on that in Singapore. So that's the idea of how can we define what health is, and then can we define what's the origin of OSA as a chronic disease, using analogies to hypertension and diabetes. So I'll talk to you a little bit about that after 9 o'clock.
Yep.
That's my new stuff. So they looked at the brainstem, isolated brainstem, looked at ninth nerve activity, was able to separate the pons from the medulla, and the ninth nerve kept going. And so that means that there's more complications to how that rhythmogenesis takes place, particularly to the upper airway. And then Eriko cut the stylopharyngeus muscle bilaterally in the rat, and it produced some flow limitation, but that it was adaptable. So seven days later, it was okay. So that shows the resiliency and the adaptability of a healthy healthy brainstem to reconfigure. And that's been looked at though for feeding in young animals. So how do you cripple that? So it's 4 minutes afterwards. So let me introduce you. Let's get going. Okay. All right. So we could talk all day long, but Seva Polotsky is an old friend. He's been involved in sleep and sleep research and in the community of sleep for many years. He had his medical degree in St. Petersburg, and then also had his MD and PhD. Went and did some basic science at Yale. Then made the arabesque to have his internal medicine training in one of the peripheral hospitals there at Yale, and then went to pulmonary critical care at Johns Hopkins. And at Johns Hopkins established a career that was looking at the consequences of sleep apnea, in particular atherosclerosis, non-alcoholic liver disease, and insulin resistance. And now he's moved to George Washington in Washington, and has started his own independent laboratory there where they're starting to get other collaborations. So Seva, today you introduce your talk, and you can share your screen with your PowerPoint, and we will listen.
Okay. Thank you very much for introduction, and let me just see I can share screen here.
You got it. Looks good.
Looks good. Okay. All right. So I'm going to talk to you today about pharmacotherapy of obstructive sleep apnea. So I have several conflicts, but they didn't really influence the topic of the talk or content of the talk. And so objectives of this talk is to describe pharmacological targets for OSA treatment and their relationship to the OSA endotypes, to describe main classes of FDA-approved and experimental drugs for OSA, and to approach pharmacotherapy of OSA in personalized manner depending on the patient's characteristics. And as you know, over the last 10 years or so, the pathogens for OSA was classified as endotypes. Obviously, it's oversimplification to some extent, but allow us to approach pharmacotherapy in more logical manner. And first of all, it's compromised upper airway should be present. If airway is not compromised, there's no sleep or apnea. Poor protective neuromuscular reflexes, we'll talk about that. And then responses to the perturbances and upper airway function with the overly robust response, which is high loop gain, and low arousal threshold, which is kind of self-explanatory. And we'll start with talking about compromised upper airway anatomy and how it has been addressed. So obesity leads to the upper airway adiposity and predisposing to obstructive sleep apnea. This is a very well-known MRI picture from Rich Schwab's paper, like 30 years ago. And it shows the upper airway in a healthy, normal individual and obese patient with sleep apnea. And you can see here, the yellow arrow points out at the narrow oropharynx. There's a tongue. See white stuff here. It's obese accumulation in the tongue and surrounding tissue, narrow airway. It's obviously not the only way obesity influences upper airway physiology. There are some multiple other ways, increase adiposity elsewhere, decrease lung volumes, but this one is really a major contributor, anatomy of the upper airway. So it's logical question, what will happen when you lose weight? And I have to tell you that that's been looked at for many, many years. And back in the 80s, I think Flip Smith published small series showed that weight loss benefits sleep apnea. And this is much bigger studies. And that's from Australia by Dixon, and that was more than 10 years ago already. And they, two groups of patients, one underwent bariatric surgery, it's on the left, and one on the right was a lifestyle modification with a diet and exercise. And you can see that was 21% weight loss in surgical treatment and 5% weight loss. It was significant improvement in sleep apnea measured by AHI. AHI significantly decreased from 65 to 39 and 57 to 43, but still remains severe. So definitely help, but remains severe. How about mild apnea? So apparently, the several studies show that weight loss can actually have a curative effect on mild sleep apnea. And this is just a lifestyle modification. This is an old paper from Finland. And they showed that when patients lost more than 15 kilos of weight, so there was a significant change in HI, and many of these patients actually recovered. On the right, it shows that they were no longer apneics. So if they lost less weight, they had less benefits, which is logical. But we know how difficult it is to lose weight. Behavior modifications, and obviously bariatric surgery is effective, but weight frequently still, there are frequent failures and weight comes back, and diet and exercise ability to maintain weight loss is very low. Therefore, there's revolutionary drugs, and that's obviously far from the first weight loss drugs. There were multiple weight loss drugs before, notorious fen-phen, which resulted in pulmonary hypertension and other drugs. But this looks like it's the first very effective weight loss drug category, which without severe adverse effects. Let's talk about this a little bit. Glucagon-like peptide 1 receptor agonist, single, dual, and triple now, and they've been introduced first for treatment of diabetes, and then actually the first drug, it's not on the slide, it's called Exendin or Byetta, and it was developed for type 2 diabetes, but was found to induce some weight loss. And they drug companies went this road and developed multiple drugs from these groups. And the oldest one, well, Byetta is oldest, but this is probably second oldest, liraglutide, single GLP-1 receptor agonist, reduced weight by about 8%, and it was significant improvement in combination with diet and exercise. And semaglutide, also single receptor agonist, was more significant weight loss reported. And finally, dual receptor agonist, tirzepatide, was developed, and it induced more significant weight loss, up to 20% in patients without diabetes and a little less with patients with diabetes. And finally, now the triple receptor agonist in development, GLP-1, GIP, and glucagon receptor agonist, retatrutide. Obviously, logical question, what does it do? What benefits it confers related to weight loss or directly related to the drug? And GLP-1 turns out to be like almost magical drug, which leads to multiple benefits related to weight loss and independent. And there is just name it. There is a very significant neural effects, and it turns out to decrease appetite, decrease addiction, decrease tobacco addiction, decrease alcohol addiction. There is a cardioprotective effect, improve cardiac function. There are some decreased hepatic glucose production. But there are some adverse effects related to decreased gastric emptying and decreased motility that turns out to actually underlie one of the benefits, how it reduces appetite, although central effects on appetite are also present, and obviously profound effects on pancreatic function. Obviously, investigator wanted to test it for sleep apnea, and the liraglutide, the oldest, one of the oldest drugs, was tested for sleep apnea already almost 10 years ago, and this was a pretty big study, a randomized controlled trial, and this, not all the patients completed 32 weeks, so some projected outcomes were statistically projected here, but there was significant benefit with AHI decreased by 12.2, and placebo, as always, placebo always gets better, right? And so there is a 6.1 improvement, very kind of modest but significant improvement with liraglutide, and was some modest weight loss. And when tirzepatide was developed, dual receptor agonist, GLP-1 GIP, was a lot of enthusiasm about it because it looks like it also has central effects, decrease in appetite, not just because action on stomach and the GI tract. So this big study, Surmount OSA, piggyback to Surmount studies by Lilly, and inclusion criteria were patients with an age greater than 18, moderate to severe apnea, and they were obese with history of unsuccessful dietary weight loss, and they excluded diabetics and any patients with upper airway surgery and craniofacial abnormality, chain stocks, kind of obvious exclusion criteria, also with gastric emptying problems, pancreatitis. These patients were excluded. And there were two trials in one. One trial was on patients who were unable or unwilling to use CPAP, trial 1, and trial 2 was patient on CPAP. And patients were in their late 40s, early 50s. They were obese for the moderate, at least moderate to severe obesity and severe apnea. Okay, and oh, sorry. So, and that was the dose of the tirzepatide was titrated exactly as endocrinologists and private and PCPs use it in clinical practice for obesity. And it starts with 2.5 dose and increase by 2.5 steps every 4 weeks, and this once a week medication, right? To maximal tolerable dose from either 10 or 15 milligram. And there were 2 points. Final point was 52 weeks, and intermediate point was 20 weeks. And on the top graphs at trial 1, patients without CPAP, and trial 2, patient on CPAP, and CPAP was discontinued. I think 3, if I'm not mistaken, 5 to 7 days before second sleep study. And so as you can see that there was significant improvement of sleep apnea with a decrease from 50s to like 20 by 27.4 events per hour, and a very similar decrease was in trial 2, and that was accompanied or because of weight loss, because it was very significant decrease in weight. This is in kilos, 18 kilos from baseline 114 kilos. So benefit was already significant for sleep apnea at week 20. But weight loss or primary effect, one may say, who cares? But I mean, I think we do care, and we'll talk about it later. Primary and secondary endpoints, change in HI was a primary endpoint, and was decreased estimated treatment difference with the placebo, -20 in one study and -23.8 in the other study, and percent change was HI was essentially halved. Still significant sleep apnea remain in a number of patients, but it was much, much better. And some patients were cured, but importantly, hypoxic burden was dramatically improved, and hypertension improved significantly. Well, there were adverse effects, but there was no severe adverse effects, okay? There was no deaths or no severe adverse effects. Okay, there are some serious events described, like a 9-event tirzepatide, similar with placebo group, and most common side effects were GI, diarrhea, nausea, vomiting, and that was most common. Well, anesthesiologists became interested in these drugs from different perspectives because they do delay gastric emptying. And this is guidelines from American Society of Anesthesiology, and they recommend to stop this drug at least 1 or 2 weeks before surgery, before general anesthesia. And there is a potential increased risk of pulmonary aspiration. Well, there are some red flags, though, besides side effects. This study is a real-world GLP-1 adherence study. And this is actually this is systematic literature review, and it doesn't include tirzepatide, and but includes others. And you see basically after, on average, most of the papers and with tirzepatide similar report only 40% of patients, around 40, between 30 and 50 in different studies, remain on GLP-1 receptor agonist after 12 months. So conclusion on GLP-1 receptor agonist: weight loss is effective for treatment of sleep apnea. GLP-1 agonists are effective for treatment of moderate to severe apnea and obesity. And the effect on gastric emptying is a barrier. And it's unclear if GLP-1 agonist effect is entirely due to weight loss. And effect in non-obese patients is unknown. And low 1-year adherence in non-diabetic. That was in non-diabetic patients. So in my lab, we actually tried to look in our mouse model of obesity and sleep disorder breathing, whether there are some primary effects. It's just very preliminary data. And we took obese mice with about the body weight about 80% higher than lean mice, and look what happened to breathing and hypercapnic ventilatory response after tirzepatide. This is single dose, and room air breathing was recorded, and baseline vehicle and tirzepatide, minute ventilation adjusted per body weight. Basically nothing changed with the baseline. Respiratory rate, tidal volume, and hypercapnic ventilatory response. If you give CO2, looks like there was some increase in minute ventilation, about 10% increase, 10-15% increase in hypercapnic condition. And this was N of 8. And that's because of increase in tidal volume. When you treat mice for 7 days, there's significant weight loss, which is obviously confounding. And you cannot weight measure them. You cannot pair feed them because they stop eating. It is impossible to pair feed. So, and it looks like minute ventilation goes up. And this is compared with vehicle here. And even without adjustment for body weight, it looks like it has gone up. And per body weight adjusted actually has gone up more, not surprisingly. And in hypercapnic environment, there is a more increase. And looks like if I adjust for body weight, looks like HCVR has increased. So we don't know whether it's entirely related to weight loss because it's dramatic weight loss. But looks like maybe some primary effects. We're planning to do some study to figure out whether GLP-1 is, whether tirzepatide acts on CO2 responsive neurons.
So what was the strain of mice? Was this the B6?
Yeah.
Well, I noticed your variability in breathing is much less.
In what mice?
In the B6, you treated the obese mice even had a reduced variability in breathing.
Yeah.
So that might be interesting. That's interesting too.
Yeah, would be interesting to know whether, we still don't know what's a primary or secondary. This Atul put this nice review together and basically summarize all the studies, Atul Malhotra, and he showed that looks like a change in HI depends actually in parallels to change in body weight, regardless of the intervention. It just shows the size of the blob, size, it's number of patients in the study, but looks like consistent. So I want to kind of acknowledge my Penn and Hopkins colleagues. So this is Rich Schwab slide. You've seen the slide. And the Hopkins group developed this concept of peak critical pressure, explaining why weight loss occurs, why not weight loss, why weight loss leads to improvement in sleep apnea, and that's related to at least to a large part an improvement in critical pressure. Critical pressure, it's a pressure here at outside tissue. This is a Starling resistor model. Upstream segment, which is nose. This collapsible segment is here. Boneless structures are upper airway, and this is trachea. And when this segment becomes collapsible with obesity, there's an increase in critical pressure and sleep apnea. So if you lose weight, it's directly proportional. This is very old study. It's probably older than some of the fellows attending this lecture, definitely. Yeah. So change in body mass index and directly proportional to improvement in critical pressure. And this paper actually elegantly explained, why some patients improve with weight loss and some and then some patients sleep apnea goes away and some don't. And that depends on critical pressure. The higher critical pressure, the more positive, the more severe collapse of the airways. And they all kind of improve critical pressure. But if it doesn't improve enough, it doesn't become negative. Because on inspiration, if you breathe on inspiration and your pressure is positive, your airway is closed. So if pressure remains positive, you still have sleep apnea. If you cross this magical zero kind of cutoff and it becomes negative, your sleep apnea either improves or goes away. So that's Alan Schwartz in 1991. Okay, now let's. All right. If there are no burning questions, I'll continue. Questions at the end, Kim, right?
Yeah. Unless there are things like strain advice or something.
Yeah. Okay. And this poor neuromuscular reflexes, I want to start with several classical studies. This study is of John Remmer, so unfortunately recently passed away. It's one of the most important papers in sleep medicine. So basically, and this is a basis for hypoglossal nerve stimulation pharmacotherapy. So when we fall asleep and we recumbent here, and our muscle, upper airway muscle, upper airway protruder muscle, or dilator muscle, which is most important genioglossus muscle, but some other muscles, obviously. If they not respond, you have sleep apnea. But what if there is activation? If there is activation, the airway will remain open, okay? You may snore, but airway will open. And that's the major mechanism of response or protection against sleep apnea. And this is not as old paper, but also very important papers. This experimental paper from Richard Horner's group, University of Toronto. He developed this very interesting model. He dialysis in conscious rats. So he basically put dialysis tube in fourth ventricle and instilled different drugs straight to the hypoglossal motor nucleus. And this is artificial spinal fluid, and this is phenylephrine. So, and he found that what will happen if alpha-1 adrenergic stimulation is introduced here. So this is sleeping rat, non-REM sleep. And as you can see that there's nothing, no EMG activity. And if you give phenylephrine, there's significant increase in genioglossus muscle, which is innervated by hypoglossal nerve. And you can see there is a significant stimulation of this muscle and in non-REM sleep, but not in REM. So, and this is actually fundamental for some of the new treatments. So let's pay attention to that. Then he tested what will happen to muscarinic axis. So there are a bunch of muscarinic receptor in hypoglossal nerve, M1, and 2, and 3. They all have different functions, and the functions make it more complicated, changing with postnatal development. But overall, the most common. Okay, so I'm sorry. I thought I had a question here. So So it's basically inhibitory overall effect of M1 muscarinic receptors. And when you block it with scopolamine, you have significant increase in muscle tone and REM sleep. But this compared with spinal artificial fluid and nothing in non-REM sleep and wakefulness. So Richard collaborated with the Harvard group with Andrew Wellman and his group, and they tested a bunch of drugs, and they found this. I'm not going through the history. They've been doing it like for at least a decade, and they found this combination of eta-oxy treats sleep apnea. So basically, it's randomized double-blind crossover trial of a norepinephrine reuptake inhibitor, atomoxetine, and antimuscarinic drug oxybutynin, eta-oxy. Atomoxetine is approved for ADHD. Actually, it's approved for narcolepsy as well, Strattera, and oxybutynin approved for overactive bladder. And then this study is very small proof of concept, 20 patients, completed study include 4 women, comorbidity were excluded, BPH was excluded because of oxybutynin. They were kind of middle-aged and obese, hypertensive, usual thing, and it was a crossover. And they found something which never seen in sleep apnea before in this first study. There is significant resolution of apnea in these patients, and improvement oxygenation. So based on that, they formed a company which I'm actually in conflict with, but I'm not going to give you any hopefully ads or anything. They found company ApneaMed, which sponsored this study. Aroxybutynin, it's just R isomer. They found R isomer is more active without as much side effects. And atomoxetine. And the study Mariposa was published in the Blue Journal 2 years ago. And they so it was obviously bigger studies, and recruited patients with a mean HI of 10 to 45, and mostly obstructive apnea, and BMI less than 38. And they excluded sleep disorders, cardiac diseases, hypertension, and patient on other medications, which are listed here. And they tested several doses of atomoxetine. Actually, single dose atomoxetine and several doses of oxybutynin, right? Okay. So, and this placebo 63 patients with atomoxetine alone, and 42 patients and 2.5 milligram of oxybutynin and 5 milligram in this group. And you see, this is a number improvement in HI. It's not great improvement, but significant. Was from placebo improved slightly, not significantly actually. And there was significant improvement from 19 to 12. But it was relatively mild apnea, moderate to mild apnea. There was some improvement. But all this group were comparable. But this group didn't sleep as well. Baseline atomoxetine 7.5. This group slept better. And the adverse effects were most common. There was no serious, like severe adverse effects. Some led to discontinuation, but most common were dry mouth, insomnia, urinary hesitation in some group, constipation. And now they're doing phase 3 studies, the Sinea and Lunea, and they actually announced this improvement, but we don't know the results unless they were presented in Chester. I don't know about this, but the preliminary press release showed AHI reduction by 55.6%, the same side effects. And Lunea, it's and the difference is duration. The synergy is 6 months, and Lunea 12 weeks, and they showed improvement. So they, how about other drugs? Actually, atomoxetine does disrupt sleep. It wipes out REM sleep, and there is some sleep disruption. And that's why the goal is to combine with multiple drugs to see whether they can sleep better. And this is oxybutynin, trazodone was tried, and lemboxirant, which are exon receptor antagonists. This spironolactone, this obesity hypoventilation, actually, cannabinoids, and a lot of drugs. There are some side effects and the variable improvement in sleep, but But this is not it, right? There are other directions of research and investigational drugs. One promising approach is actually topical application of the drug, completely different approach. Basically, by nasal spray, you apply this to the tongue, nasal spray. And in this case, in most common drugs, as a task 1, there is also task 1 and 3. This is acid-sensitive channels, potassium channels blocker. And what happens, they block potassium channel, increase muscle activity because inhibitory channels, right? And this study is in pigs. So what they did, they induced tracheostomized pigs, they close airway, just suck the air through the trach, and they look what happens to whether the flow will restart if you give a drug. And this is baseline, and when they give this drug, there was a very consistent improvement in the EMG with genioglossus EMG, and airway open up. So, and that reduce pharyngeal collapsibility in response to negative pressure. This is in pigs, but when they tried this in humans, it didn't really work as well. So, and this is small studies in humans and with the BMI, and this basically shows no change in HI. Should we give up on this drug? And well, they don't think we should, because if you phenotype patients, like you essentially phenotype for hypoglossal nerve stimulator, right? I mean, you may find responders. So, but what they found, that patient in whom critical pressure in response to spray improved, basically airway open, their sleep apnea was much better. And those who didn't respond, sleep apnea did not improve. And then try to predict by AHI, ODI, didn't work. PICRET predicted response. And that's when it worked, the blood pressure improved. Well, in my lab, we're interested in leptin, and we found that this adipose tissue secreted hormone was very active and very beneficial in a mouse model of sleep disorder breathing. These are BRB mice leptin deficient, and this is their sleep studies. Obese mice, EEG, EMG like human sleep study, flow and effort, and the inspiration is down. They have a flow limitation, and when you give them leptin, it goes away. And in DIO mice, you have to give leptin intranasally because there is a resistance to leptin sub-Q. So basically nasal spray, and it also goes away. And we try to take it to clinically. Unfortunately, the main obstacle is the cost. Like and cost entirely driven by industry. Basically, there's no reason for this to be that expensive. But anyway, that's it is. So we're now looking downstream of leptin pathways, trying to kind of find something efficient which is not that expensive and more practical. So these adipocytes secrete leptin, and leptin affects this secretion of MSH, alpha melanocortin stimulating alpha melanocyte stimulating hormone receptor for which is melanocortin 4. And this receptor increase satiety and increase metabolic rate. And attractive thing, the drug is approved for obesity in patients with genetic obesity. It's about, in the childhood obesity, about 6%, 5 to 6%. Obesity is genetic due to deficiency of melanocortin-4 receptor or leptin pathways. An approved drug is called setmelanotide. We tested this in mice, and we found that it increases maximum respiratory flow and increases minute ventilation and respiratory rate and decreases apnea, predominantly central, but decreases apnea. And in REM sleep does the same and improves response to CO2. And very recently, we measured gene-gloss activity like it's measured in Richard Horton's lab during sleep. And they found that setmelanotide significantly increased gene-gloss's muscle tone in non-REM and REM sleep and response to CO2. So my collaborator, David Mendelowitz, and his lab, they've been interested in oxytocin for a long time because it's actually cheap and that's has very little side effects, except obviously in pregnant women. And the intranasal oxytocin increase phasic EMG activity. This under anesthesia, and oxytocin receptor they express. It's interesting. Express predominantly in protruders neurons and genioglossus hypoglossal motor neurons, which supplies genioglossus muscle, and that's protruder motor neurons. And this brain slice. And they patch the hypoglossal motor neurons and they fire, they give oxytocin. And actually human studies were done and they showed a mild benefit, not really a huge benefit, but it's a small study. There was some decrease in hypopneas. Okay, we'll keep monitoring. And let's talk about high loop gain. What is loop gain? So if you think about like critical pressure, and we talked about critical pressure, and we talked about neuromuscular responses, and but it's kind of, we're talking about one breath, right? But we breathe in all night and all day. Breathing is an essential function of living organism. So if we stop breathing or our breathing decrease, CO2 goes up and the body responds by hypercapnic ventilatory response, right? And if responds to chemoreceptor and mechanoreceptor as well, I have to tell you, if this response is too much, overly robust, the system becomes unstable. That's very well known in engineering, and the system becomes unstable, and develop this oscillation, engineering term is loop gain. So when response to positive loop gain, high loop gain, when response to disturbance is much higher than disturbance itself. And so the first actually way to treat high loop gain is oxygen, right? I didn't include that, but if you give high levels of oxygen, you blunt this loop gain, and that has been used by doctors in practice of medicine for a long time. Acetazolamide, carbonic anhydrase inhibitors, was shown to decrease loop gain. And this Brett Edwards studies more than 10 years ago, and he found that when he measured loop gain and in patients who responded by loop gain, or patients with elevated loop gain, rather, acetazolamide treated sleep apnea. But there's one subject in whom acetazolamide did not improve loop gain, still remain apneic, and even that it has gotten worse. So he concluded that acetazolamide may work in patients with high loop gain, so which requires obviously phenotyping. And the group in Sweden with Jan Hedner, they been working on alternative inhibitors for a long time. And they developed this, actually they didn't develop it, this drug's been known before, but they utilize this drug, sulfam, for treatment of sleep apnea. And in these studies, they look at the patient from 18 to 75 and included patients who were normal weight, overweight, and obese, and with a mild to severe apnea, and exclusion criteria, CPAP, chain stocks, and other sleep disorders. And they studied several doses of sulfam, and they found that and this is baseline characteristics. They randomized to sulfam 200 milligram, 400, and 400 milligram. Okay. And just pay attention that most of the patients were overweight but not obese, right? So what they found that, this group included 22 patients placebo, 12 with sulfam 200 and 25 with 400. They found that the sulfam significantly improved apnea with the decrease and decrease was minus 20 events per hour. They still had significant apnea, but it was much better. There were some side effects, and some most common side effect by paresthesia, which is a known side effect of carbonic anhydrase inhibitors, and also headache, and some other side effects. But paresthesia was most common. So benefits: it decrease AHI, both in REM and non-REM sleep, and it decrease arousals and ODI, and it's decrease in one sleep. It had minimal adverse effects for sulfam at 200 milligram with preserved efficacy. And although there was no improvement in Epworth or quality of life, and there's some residual sleep apnea remain. And but the patients were not obese, so we don't know whether it will work in severe diseases, patients with severe disease. There are other drugs focusing on loop gain, and I'm not sure. I mean, this is a combination of cannabinoid and acetazolamide. Cannabinoid was tested before by David Carley's group, and they were helpful in small subset of patients. I don't know why they combine it here, but looks like it improved total AHI in the studies, and there's some improvement in baseline. This is very small studies. And there was at low dose, it was significant decrease in loop gain. And what's interesting, the high dose looks like collapsibility. They measure collapsibility based on routine sleep study, not by CPAP pressure drops, but they found improvement in collapsibility. Well, this is just entirely speculative. There is a speculation what sodium glucose cotransporter SGLT2 is a very common new drug for diabetes, may improve loop gain. But I haven't really seen the data. I've seen it mentioned in the publications. It improves everything else, as you know, in diabetes, and improves cardiovascular outcomes, and improves ejection fraction even. So we are now down to arousal threshold, and it's, well, there are different phenotypes of sleep apnea, right? I mean, if you kind of have a phenotype when you cannot really tolerate even very small increase in CO2, you wake up, you have low arousal threshold. It's especially common in young premenopausal women, but you can see it in men as well. And so if you give this, this study was done by Danny Eckert when he was at Harvard with Atul Malhotra, and they showed that Zepiclone decreased AHI in patients with low arousal threshold, and a patient who did not have a low arousal threshold, there was no improvement. They tested zolpidem, and they found that sleep efficiency improved, total sleep time improved, so WASA improved, but AHI did not improve. And hot topic now, it's orexin. Actually, it's hot topic, both orexin receptor blockers, which we'll talk today, but agonist, maybe some other talk somebody will give you. Agonist is very hot topic as well, but for different disorders. Oops. Orexin is produced by only 800 neurons to 1,000, I think, in lateral hypothalamus, but it's basically, they project all over the brain and everywhere, and to brainstem, serotonergic nuclei, RTN and CO2 control, locus coeruleus, and NTS, phrenic, hypoglossal, everywhere. And so basically, and it apparently orexin knockout blunts hypercapnic ventilatory response and improves blood pressure. And this I think it's meta-analysis, right? It's only 4 studies, small meta-analysis just published of dual orexin receptor antagonists. There are 2 receptor, 1 and 2, right? And they look at only a dual receptor agonist, daridorexant, lemboxirant, and suvorexant. And they found that there is improvement in total sleep time, sleep efficiency, maybe REM, and there is no significant effect on HI, but basically sleep, but you sleep better. So, and finally, a logical thing is probably combination therapy. And in this study, there was a combination, they try to target everything, acetazolamide for high loop gain, Zepiclone for low arousal threshold, and poor protective neuromuscular reflexes, well, venlafaxine, which is a Effexor essentially, right? And they use it in this trial. And BMI was less than 40, and hypopneas were more than greater than 25% of the events in crossover design. And they used this is dual approach, acetazolamide and Zepiclone, and this is triple plus venlafaxine. And as you can see, there was significant improvement from baseline in dual approach, and no additional benefit with venlafaxine. And overall conclusion, I'm coming to conclusion now. OSA pharmacotherapy is a valuable alternative in patients who are unable or unwilling to use CPAP. It's not a replacement. It's still a valuable alternative. It can be personalized depending on the disease endotype. Similar to other common chronic diseases like hypertension, asthma, COPD, the future belongs probably to combination therapy. And I'd like to acknowledge people who work with me, and this is my lab at GW, and this maybe you know some of the names who graduated from my lab, like Lou Pham, Jonathan June, Omar Mesarbe, and Denise Kim, Luciana Drager. I'm sure you know Tomas, who worked with me for I think 5 years, and this my collaborators, David Mendelovich, generous NIH support, and American Heart Association. Thank you very much.
Terrific.
Thank you.
Questions? None in the link. Stunned silence.
Well, excellent talk. I really enjoyed it, but I have, of course, a lot of questions. So my first question is about GLPs and weight loss. So,
Sorry.
so the first question is GLPs and weight loss. So how durable is the weight loss? So when people, lose their 50 pounds and their sleep apnea, significantly improves or resolves, is there any data? I'm not expecting you to know this. Is there any data to say, hey, this weight loss lasts for 2 years, 3 years? Because that's a major stumbling block where people, will lose weight and then regain it, and you're back to where you started.
The answer is that they probably regain weight. It's kind of like there are some data, not a lot of data, but there are some data that people do regain weight. There are some data suggest they don't regain all weight, but that's not a very long observational period. So there is and concern. This is just a concern. I have no data to confirm it, but I'm concerned if they gain more fat than muscle because they also lose muscle.
So second question is, we have different meds for different issues related to sleep apnea. Are there any trials to say, hey, we've used, a medicine, acetazolamide and CPAP? In other words, some of the medicines may help people tolerate CPAP better. It may not be just a matter that they're claustrophobic, but some of the medicines may actually help people tolerate CPAP better. So which of the medicines do you think would do that the best, to sort of put them on medicines and CPAP therapy?
That's a great question. It's been used for, as you know, for low arousal threshold, for sleeping pills, for GABA agonist for a while, and people use it. There is a lot of, I don't know, some of you maybe try to, who managed to get insurance approval, try to use GLP-1 agonist with CPAP. But that doesn't, it may actually, there is no data. There is a data that there is no data if GLP-1 agonist will increase adherence to CPAP. But I think they might, because they increase, sobriety on abstinence. I mean, they may just increase compliance with CPAP. I'm not aware of. Maybe Kinman knows. I'm not aware of acetazolamide and CPAP together trial. I don't know this, but
I'm bringing out acetazolamide and buspirone for emergent central apneas, but that's only after you figure that out. There was a study at Walter Reed that took placebo-controlled and used sleeping pills for 21 days with the initiation of CPAP, and said that they improved adherence by 10–15%.
Right.
So that would be a short term. That's a short term, but they didn't identify any of the traits of the people whom they gave it to. And that was, I think, I've forgotten what brand they used, but it was a benzodiazepine.
Yeah,
maybe these other sleeping pills work just as well.
Okay.
Well, great talk. Thank you very much.
Share good resource for physiology. Some asked me to share good resource. Why don't you read my chapter? Book of neurology. Sorry,
Good. All right.
Yes, that would be great. Thank you.
Any other things going on? Sally needs to leave. Dennis, I liked it. The other thing that people are pulling out, I think, I remember progesterone for obesity hypoventilation syndrome. And then there was a crazy study, there was an abstract form from Brazil that used 6 different drugs instead of. So there are some things like aminophylline for central apneas that were tried in the 70s and 80s as well.
Yeah.
But it turned central apneas into obstructive apnea. So that was sort of interesting too. I don't like to call it Luke-Gate anymore because people kind of focus on loop. I just call it a game. And just say that's what it is. That's it. Anything else here? Anything
Yeah,
else
I
on
don't-
the line here before we close up the, we're gonna keep on with the fellows. The fellows are, they look like they have burning questions. No, what do you think? Maybe they're just burning. Maybe that's it. Okay, well, we'll try to see what happens here. Okay. Any of the fellows have questions? Any? Yeah, Erica.
You show the overview of the GLP-1's effect to organs. And then in the brain, it says for the brain, the GLP effect for neuroprotection and safety and something. And so it's not your articles, but what's the neuroprotection and safety for the brain?
for the brain. So yeah, there are some. So basically, the effect, multiple effect for the brain, GLP-1 agonist. What's really known, I can tell you, there are some anti-inflammatory effects we described. Anti-inflammatory effects of GLP-1 agonists. And the other effects that obviously, and it's quite obvious, it's probably its effect on addiction and dependency. And there is it probably acts in amygdala, but it's not really clear how it works. At least I don't know how it works exactly. And I know that GLP-1 agonist in the brain is all over the brain. And that's why, and many function is not exactly clear. Like for instance, cardioprotection, how much is it because of weight loss? We don't know that. And I didn't answer your questions, but I told you what I know.
Thank you.
Good. Anything else, Sam? When are you gonna use these drugs in the clinic? We're walking into clinic this afternoon. Yeah, you are. Are you gonna pull these out? What are you gonna pull out? I know AMA is using, not using the combination, but using what's available at the VA, but the side effects of some of the cholinergics, urinary retention in the older VA population is not terribly useful. They really have some trouble. So she stopped doing that, waiting for the next drug to come. Any questions here? This guy's been thinking about this stuff for 25 years. You've been thinking about it for a year and a half, 2 years, so.
I've got another question. So if you have somebody with a high AHI, mostly obstructions, no centrals, and they can't tolerate CPAP, and their BMI is 26, 27, is there one medicine that you would say this would be something to try for sleep apnea, either to just to sort of help a little bit, with the AHI, and maybe even say this would help with CPAP?
Yeah, that's a great question. So if they sleep, I would find out why they cannot tolerate CPAP, right? I mean, sometimes you don't know. Sometimes they just can't sleep through that. You can try.
So,
Yeah.
so for instance, say they just can't tolerate CPAP because they feel the pressure is too high.
Oh, that's a good question. So did you try?
Benzos, do loop gain and then hit their sensation and arousal.
Yeah, I do put them on the zolpidem. And in the future, I can't tell you because of the conflict, but what else I would try? I feel like I would be biased, and this drug is.
So would you? Let me ask you this: would you, instead of zolpidem, would you try some trazodone? Because it would be easier to get that approved from an insurance standpoint.
Trazodone does have some effect on apneas.
Yeah, trazodone. There are some positive study with trazodone. Yeah,
but more negative than positive. But if you're trying, you're just trying.
Yeah, you just try it. There's no, and it's another thing that I know in other countries, like in Brazil, they used GLP-1 agonist even in overweight people, but it's not possible in the US. And if patient is diabetic, that's I like. Well, I love when patient diabetic because then they can go on Manjaro, and which is a generic name for another generic name for tirzepatide. But yeah, GABA agonists like zolpidem,
Thank you.
I mean, you can use oxygen often you have to do backflips to get oxygen to a patient, but they usually have to have some degree of cardiopulmonary problems to be able to justify it. But oxygen is a third level, suggested as third level with really very little evidence.
What if they've got, what if they're, on their original sleep study, they've got, low O2 sats and they're greater than 5 minutes to qualify for supplemental oxygen. Would that be a way to do it?
Well, they've kind of gotten around that now by you have to have an overnight oximetry. And then you have to show consecutive minutes. So we can always pile up the hypoxic load. And then they have to have at least to do it for pulmonary, you then have to also have pulmonary function tests within 30 days of doing the oximetry. So you can do it, you just have to go through the ski slalom course to get to the end.
Yeah, you have to show that the SAT is less than baseline is less than 88% or less than 89 with comorbidity, like usual Medicare guidelines.
Yeah, but the oxygen guidelines don't get it if they have sleep apnea, and you're looking at, it doesn't even happen with a overnight with a HST, John. Use an HST in a person whom you want to give oxygen to, you have to go back and do overnight oximetry and pulmonary function tests.
Yeah.
But bottom line is that's a possible way to get the oxygen paid for. That's the bottom line. I mean,
Yeah.
Now, the other reason that the Tramadol was going with Ceazolamide, they realized that people were on the Tramadol, that increases hypoxic sensitivity through reflex of the superior cervical ganglia. And it was increasing hypoxic drive, so it increased gain. And so that's why they added the Ceazolamide to that. That's in phase 3 trials right now. So that's
okay. Oh, that's interesting. That's why they added it. Okay.
that's why they added it.
Mm-hmm.
Do you know if the atoxamine, if AD109, if you stop it, do they how quickly the apneas come back? Is there any data or any rumor about that? I don't know. And
I don't know how no, I don't think there is data, but I would imagine it will come back.
I mean, I think that on the other hand, it could reset your brainstem, stability. That's
You mean with AD109? No, I think it will come back.
Yeah, but the thing is, why is it deficient in the first place?
Why is it efficient? Because of norepinephrine stimulation of the genia glossus.
And why is that impaired in people who are thin and who have an airway, and the people that have retronathia? 50% of people with retronathia don't have sleep apnea. Huh?
Well, you're asking all these questions. Why? I think I just recently saw reviews like 30% of patients who are not obese and have sleep apnea, not obese, not overweight, have sleep apnea. Nobody knows why they have sleep apnea.
That's what we've been thinking about here. I'm trying to flip the script a little bit. I think that whether or not the That's what I'm thinking about here. That's the idea. That people, we always start off with all the descriptions of the clinical descriptions, and we sort of go, it's a 49-year-old with diabetes and hypertension and this sort of stuff and that sort of stuff. Well, you know, the diabetes and the hypertension didn't start last year like the OSA did. No, it didn't start last year either. And so there's a literature there that says hypertension and diabetes affect brainstem function.
Sure.
And so it could be the cumulative effects of brainstem. I call it inability the adaptability and resiliency in the face of problems.
So, and another concern about pharmacotherapy, I didn't discuss it during the lecture, but it's almost inevitable, but it's very difficult to find a drug which will activate a neuromuscular response without arousal. You know, it's an issue, and not only that, I mean, some of these drugs, they stimulate everything. They stimulate like hypoglossal motor neurons, and they stimulate carotid body, which is not necessarily a good thing, you know. Yeah, so it's yeah, there are some issues there.
Anything else? I mean, what are these guys going to be thinking about 5-10 years from now? It's going to be combinational therapy. It's going to be being able to identify phenotypes from the PSGs that they're learning how to read. It's going to be those particular things that are tell you, and it's going to be people, I think, that are CPAP intolerant. So that's going to be the focus, I think. People are going to ask about whether or not it can replace CPAP, but I don't think it'll replace CPAP initially.
No, I don't think so. I think you're right. I think people who can take CPAP will be on combination drugs like hypertension, you know. Yeah.
Who do you think is going to be prescribing these things the most? Primary care practitioners or sleep doctors? I mean,
Yeah.
they could, GLP-1 is a good example. It can be prescribed almost by anybody. And whether or not the AD-109 can be prescribed by primary care docs, and so they'll try it for a month, it doesn't work, and they'll send them to us.
Exactly. I think that's going to happen. Yep. We'll end up with these patients anyway, because they'll, you know, I'm sure we're in business.
So the other thing I'm thinking about is we gotta flip the script on CPAP. We need direct-to-consumer CPAP. Like you have direct-to-consumer hypoglossal nerve, we need direct-to-consumer CPAP. You know, what kind of therapy that works, that only works when you're asleep, you know, or you know what color pajamas you're wearing when you're asleep, or, you know, because the technology is a lot better, a lot easier, a lot quieter. Mass selection is much better.
Yeah.
But
what do you mean, Dr. Stroll, what do you mean by direct-to-consumer CPAP? Like,
right on the TV. I wear CPAP instead of saying no hose, no this, no this, no that for the Inspire. It would be
Yes.
I put this thing on for I fall asleep in 5 minutes and I wake up and I take it off and it takes me 2 minutes, and that means you only wore it for 7 minutes that night. That's what I mean, John.
Inspire commercial is very aggressive. It's not entirely.
I want to be just as aggressive on CPAP. So the CPAP is demystify it and have a bunch of people whom they, you know, have all sorts of people that say it works really well and I use it every night and this is what it is. And
no, I
you know what
I think
mean?
I think that's reasonable. It takes me at least five minutes to explain why, you know, Inspire's not that simple. You know, I did it, and it's not as easy as it looks. If it was like that, we wouldn't be using CPAP. It's not. It's not.
No, the original ones for Inspire had no disclaimer. I complained bitterly, and I complained bitterly to the company. I should have complained to the FDA because they didn't even mention it was surgical. They didn't mention it was not for everybody. They didn't mention any of those things. Now you have a disclaimer at the back then in which, you know, they don't have mortality in putting it in, but they could have put, you know, like they do for all the drugs, they say including death, right?
Right,
And
right.
usually they're playing it out with a musical thing over it, and people are dancing with Manjaro and doing all sorts of stuff. So I think the idea would be to sit there with CPAP and get a bunch of marketing people around and get a bunch of marketing people that use CPAP on a regular basis and say, how do you sell this?
It's interesting concept.
I've got one more, sorry for all the questions today.
That's fine.
So,
That's fine.
in terms of timing of when we give these medicines, is there, you know, obviously when you're going to give, you know, trazodone, zolpidem, you're going to give it at night. The acetazolamide, is there any benefit to giving that at night, or that's always, you know, twice? Like for instance, we're not treating, you know, idiopathic intracranial hypertension. We're not giving it during the day. I mean, is there any advantage to timing, you know, of when we would give that medicine?
I still, when I had patient on acetazolamide, I still was given it at night, even that it's, you know, it's a mild diuretic as well, but these people usually get up at night to pee anyway, so.
Okay.
Well, I give it at night because the numbness and tingling doesn't wake them up.
Yeah, that's true too. Yeah.
It's present during the daytime.
Yeah.
And the only craziness is that it really changes your acid-base balance. It lasts for about 16 hours, but it changes your acid-base balance. So if they have their comprehensive metabolic panel at 7 o'clock in the morning fasting after they've taken their acetazolamide at night, they usually get sent to the ER because everything is so screwed up.
Because
But
it's
it normalizes.
no just no bicarb.
But that's how it works. I mean,
Yeah.
now the Upjohn at one time had a progesterone that only worked on the brainstem. And that would be, but you know, that it's off patent now. So Lilly, who bought Upjohn, is sort of.
Well, in women, it's known that you know that sleep apnea changes throughout the cycle as well.
Right, so a small dose of brainstem. Then Dempsey showed in rats that you had to give estrogen first to get the progesterone receptors in the brainstem, and then you could give progesterone to produce hyperventilation in the rat. But
right.
I don't know if that's really true in humans.
Yeah.
Good stuff. Okay, well, thank you very much for staying around, John. Thank you.
Oh, thank
Great.
you.
Thank you very much. Great talk.
Thank you.
All right.
I appreciate
Okay,
it.
good.
Bye.
All right, good, thanks. I'm gonna sign off.